Hi, everyone. Welcome to Chapter 10, the muscular system. This chapter is looking at the anatomy, the names, the origins and insertions, and functions of the muscles. There is a lot of overlap with what we're doing in lab. So you'll notice that on Canvas, I have a list of the muscles that you're responsible for. I'll point out just a couple in this lecture that are different than what you may have had in lab, as well as some additional insight into them. I'll try and be clear about which muscles you need to know and which muscles you don't, but I don't know that it's helpful for you at this moment to point at every muscle of the body. So if I have tips and tricks for remembering them, of course, I will share them. But know that even though I don't go over every muscle step by step, that doesn't mean that it's not something you need to know and be aware of. Okay, disclaimers over, let's go. We love our functions in AP1, functions of the muscular system. We've got axial and appendicular, and you'll want to know what falls into which category. Our axial muscles support and position the axial skeleton, while our appendicular muscles support, move, and brace the limbs. And we've got about 700 of them, which vary in size, shape, and function. And we're going to want to know for skeletal muscles, how are the fibers arranged and how do they attach to the skeleton? Because once we know those things, we can determine what pattern of movement they provide for us. And then that helps us clinically if there is pain on a certain movement, that will help point us to which muscles they could be that might be diseased. So here is an image of that fascicle organization and leverage. And so the organization is going to determine not only the power, but also the range of motion. So our possible organizations, we have parallel muscles. Parallel muscles, all the fibers are parallel. They have an origin and an insertion. And the fibers run parallel to that origin and insertion. While these fibers look a little bit oblique on this rectus femoris view, I like to, in my mind, think about them just as more parallel train tracks that go from one end to the other. We've got convergent muscles, so they converge to a smaller point. They're going to start and have a wider opening, and then well, not that, but then they'll converge into something smaller. Now, let me clarify with these that just because it goes from wider to narrower doesn't tell us what the action is going to be and what the origin and insertion are. Those are determined by how those muscles move. We've got pinnate muscles. Pinnate muscles look like a feather and have a little bit longer zone of attachment to that tendon. So here we've got a unipinnate muscle where the fibers are running a little bit oblique. We can have a multipinnate muscle where the fibers run oblique and meet in a central area. And then we can also have circular muscles. So our orbicularis oris and our orbicularis oculi, those are our circular muscles that we have. So the organization of the fascicles and where they attach in the body is going to determine how they create the leverage that causes the action. I'm not planning to ask you about what kind of lever it is. I will let you enjoy that when you take physics. You will have more than you ever wanted to know. But just a brief pointing out of how things work. If we have a first-class lever, the load and the force are on opposite sides of the fulcrum. And so the example of that is our neck extension. So our fulcrum is right here, kind of near that mastoid process. We've got force that is pulling inferiorly from those splenius capitis and semispinalis capitis muscles, and then that's going to move the load upward, even though it naturally seems to push downward. A second class lever, the load and the force are on the same side of the fulcrum, and the load is closer to the fulcrum. So here we're showing plantar flexion at the ankle joint. Here's our fulcrum. The load comes right down this tibia to that tarsus, but the force that we're going to use to oppose that is the gastrocnemius muscle that's going to allow us to lift that heel. And then the third class of lever is flexion in general. So here we've got the fulcrum with the force on its end and the load further away. So an example of this is the biceps brachii muscle. The elbow is our fulcrum, and the load that's pushing downward is the weight that this person's lifting. But the biceps muscle is going to apply force upward or superiorly that's going to allow the weight to be lifted. So this is key. Put big stars here. We want to know these muscle terms and recognize that these muscle terms are all based on how the muscle is moving. So the origin of the muscle is the fixed end of the muscle. Please note, this has nothing to do whether it's inferior or superior. It is truly which part of the muscle is not moving and which part is actually moving some kind of bone. And that part that moves the bone or moves the structure is the insertion. So sometimes if I'm not sure which is the origin or the insertion, I will actually do the action and kind of see, okay, which part of the muscle is staying still and which part of the muscle is moving. You will have an agonist, which is a prime mover, and this is responsible for producing a movement. So the example here we have is our elbow joint. In this case, the biceps muscle here is our agonist. It's fixed here up at the scapula and the head of the humerus. It is, and that's its origin. It inserts on the radius and then is going to allow that action. Now, synergists help the prime mover. They either will provide extra pull or they'll provide stabilization. They're not doing the heavy lifting, but they're helping. And so in this case, we're looking at the brachioradialis muscle that is helping that biceps brachii muscle. And the antagonist is the action opposes the agonist. So if you think back to your English days, antagonist is kind of the villain or the enemy that's trying to make the characters work harder. In this case, the antagonist is doing the opposite of the motion. And so in our example, the triceps are our antagonist. And because instead of flexing the elbow, they are going to be trying to extend the elbow. Now recognize that these are relative terms depending on the type of movement you have. So when you're talking about the origin and insertion, you're going to be talking about a muscle. So the origin of whatever muscle, the insertion of whatever muscle. When we're talking about agonist, synergist, and antagonist, you're going to want to be doing an action. So it's an agonist for flexion of the elbow, and you'll have a joint involved in that. So these are all relative terms. So for example, if we change our definition and our goal to describe extension of the elbow, in this case, our triceps muscle is going to be the agonist because it is the prime mover that's extending that elbow. And the biceps muscle is going to be the antagonist because it is the muscle that is working against that extension. You want to be able to label or determine based on a particular action what the origin, insertion, agonist, antagonist, and synergists are. So here is an overview. Again, please don't get overwhelmed by these images. Use the list that's on Canvas to help you focus in on what to study. These images just provide other views. It may be helpful to even crop the image and remove those labels and see, if you don't need to know it, you can mark out the line, but remove those labels and practice filling those in on the diagrams. Great practice for lab as well, since you'll need to know how to spell things. So there's four groups of axial muscles. I do want you to know what the four groups are. You've got your head, neck, facial expression, extrinsic eye muscles, your tongue, and your pharynx. These are all associated with the head and neck. You've got your muscles of the vertebral column. So we're seeing those here going along the spine, trying to help support that. We've got the muscles of the trunk, and those are our abdominal muscles. And then we've got the muscles of the pelvic floor. I bring this to your attention because if you remember in the skeletal system, the pelvis was included in the appendicular skeleton. In the muscular system, the muscles of the pelvic floor are included in the axial skeleton. And that's because they are really a part of that main supportive posture. They're not attempting to necessarily move limbs. So we've got the muscles of the facial expressions. So these all originate on the skull bones, but instead of inserting on another bone, they're going to insert on the superficial fascia and the dermis of the skin. So, if you lift your eyebrows up, the part that's moving is that skin or that insertion. And that's its action to move the skin to allow us to have facial expression. There's a few muscles I do want you to be aware of that we're not looking at in lab. These are things like the corrugator supercilii. Corrugator, think of corrugated cardboard or something that's corrugated and all folded up because they corrugate or fold up the skin. You've got your procerus muscle here between your eyes. And then you've got this platysma muscle. It's a very thin, very long, very spread out muscle, very superficial on that neck. And then a little question here, what muscles do you think they inject Botox into? Well, if we think about it, definitely this frontalis or this frontal belly of the occipitofrontalis. That's where people talk about Botox face because they can't lift their eyes up really well. That muscle is paralyzed. But when you can't move the skin, you can't put wrinkles in it. So that's kind of the goal. Other muscles you think about are your orbicularis oculi, your orbicularis oris, and then that corrugator supercilii, and then your procerus as well. Botox is actually comes from the bacteria Clostridium botulinum, which is not helpful for us in real life. It causes paralysis. This is why you don't feed honey to infants, is because there is a risk of them having botulism. This is why you don't eat canned foods that the can is like expanding because you worry about some kind of bacteria there. But in this case, we grow the bacteria, we get the toxin out of them, we purify the toxin, and we inject it to purposely paralyze those muscles. We're going to look at the extrinsic eye muscles. You'll see these again when we look at the nervous system, but now is a great time to go ahead and learn those. The nice thing is most of them do what their name says. So we've got our medial rectus that's going to rotate the eye medially. Because I know this is the medial side, I can tell that this must be the right eye. We've got our lateral rectus, which is going to rotate the eye laterally. Rectus, you can think of like ruler. It means straight. And so it's pulling it straight that direction. You've got your superior rectus that's going to let you look up so you can roll your eyes. And then you've got your inferior rectus so that you can look down. There are two other muscles, and these are the oblique muscles, and they are responsible for this rotation of the eye. So you have your inferior oblique, and if we look here, we can see that inferior oblique, it goes from the lateral part, so we're kind of underneath that lateral rectus, and then comes around to the bone here. And it, when contracted, allows the eye to look superiorly and laterally. So for the obliques, I kind of remember that the term that it has in front of it is going to be the opposite of the way the eye's going to look. And then you've got your superior oblique, which has this special little contraption here called the trochlea. Trochlea, we saw in the humerus lecture, it means pulley. And in this case, it is truly a pulley. And so it is part of the bone, part of the tissue here, and it's going to make the eye look inferiorly and laterally when that muscle is contracted. This becomes important because we're going to talk about the trochlear nerve and the nervous system. And so if you kind of remember that superior oblique goes through the trochlea, then when you hear about the trochlear nerve, you're going to know, well, that's obviously the muscle that it moves. We've got the muscles of the vertebral column. I'm not expecting you to know all of these. Again, look at what's on your list in Canvas, but these are our anti-gravity muscles, and we've got several layers of them. You can see some are longer, some are shorter, various origins and insertions, and they run from the sacrum to the skull. There's not many flexors on the vertebral column, and for that, why that is, think about where the weight of your body is located. So if you're relaxed, are you more likely to kind of fall forward? Or are you more likely to fall back? You're more likely to fall forward because most of our body weight is on the anterior portion. And so that's why we don't need many flexors. It happens naturally, but we need lots of extensors to kind of help keep us upright. Do you know for your exam why there are few flexors and more extensors in that vertebral column? We've got the pelvic floor muscles. We're not going to go over these in detail, but these are a huge emerging area of medicine, of study, of practice, of development. So once you hear about the pelvic floor muscles, you're going to hear it. You're going to see them and hear about them. I mean, you're not going to see anybody's pelvic floor muscles, but you're going to hear about them everywhere. The muscles of the pelvic floor are really important for sexual well-being, for labor and delivery, for urination and bowel movement. And when there is dysfunction, you can see incontinence, constipation, you can see sexual dysfunction. So they are super, super important. These are muscles that can become really weak or torn during labor, and then and that creates what some of my friends call, you laugh a little bit too hard and you pee. And so lots of physical therapy and medicine is going into how can we strengthen these muscles. And it's not just Kegels. Kegels are practicing contraction of that pelvic floor, but there are lots of other ways that pelvic floor can be helped, because we want to make sure that everybody is continent, that we have good sexual well-being, and that we're not experiencing constipation. So know the functions of these muscles and what weaknesses those in the muscles we might experience. You don't need to know all of these muscles at this time. We've got muscles of the trunk. Know that in our category of axial muscles, muscles of the trunk include the oblique group. And that's not only your external and internal obliques, but also your transverse abdominis, your scalenes, and your intercostals. And then you've got your rectus group, which is your diaphragm. Little star here. You don't really think about your diaphragm being in the rectus group. It is in the rectus group. And then also your rectus abdominis, which makes a little bit more sense. These muscles become important surgically, because if you're doing surgery, you want to know, one, how many layers of muscle do I need to cut through before I get to the abdominal cavity? Because you don't want to be overzealous in your cuts and cut an organ that's in that abdominal cavity, but also you want to be efficient. You don't want to kind of like dissect a bunch out and make more damage to that area than you need to. In surgery, when you're doing a big abdominal surgery, our goal is to make the incision on this linea alba. So in this image, we have anterior and posterior. The specimen's on their back. And that linea alba is fibrous tissue. It doesn't bleed a lot. It heals well. And there's not a lot of layers between it. So that's always, if you're doing a anterior midline incision, try and see that linea alba so that you do less trauma and your patient recovers quicker. So appendicular muscles, again, you'll know these from lab. I'm going to do just a little bit of review, give you some tips and tricks. We've got the muscles of the trunk. So we have anterior and posterior. And if you look at these images to give you some orientation, on the left, you have a superficial dissection, and on the right, you have a deep dissection. So we got our sternocleidomastoid here. Remember all the muscles that you needed the origin and insertion for in lab. I want you to have those here as well. And then there's a couple of little bonuses. So I want you to kind of be aware of your splenius capitis that runs down the posterior portion of the neck. We've got our levator scapulae here. Levator meaning to raise up. It's going to help raise up the scapula. You've got your erector spinae muscles. And so these run on the posterior portion up and down your back. And the reason I add these to our list is these are muscles that might be massaged to help relieve stress. So muscles to massage, if I give you a bigger list, we think of that splenius capitis, we think of our upper trapezius and the levator scapulae. We think of the rhomboids. Remember, rhomboid is that like special little shape that the muscles make. We could use our lower trapezius, our erector spinae, or the infraspinatus. So if asked, hopefully you could say one muscle that you might want to massage at a typical massage. I'm looking to see if there's any other special tips. Here's that platysma muscle. We looked at that when we looked at the axial skeleton and the skull and neck. We've got a nice image of the obliques kind of pulled back a little bit. And you can see here the gluteus medius under the gluteus maximus. Kind of nice to be able to have an image where both you can see the way the fibers go and you can see a little bit where that gluteus medius attaches to. Okay, appendicular muscles, we got our pectoral girdle. So these are what are going to attach our arm to our axial skeleton. In this case, know the muscles of the rotator cuff. Super, super, super important to know those. You have your subscapularis, your supraspinatus, your infraspinatus, and your teres minor. It's not the major, it's the minor. So kind of remember that this minor muscle does a major job. Where can we see those? So the subscapularis is a little challenging to see on this view because it is on the anterior portion of the scapula. And so we're not really able to visualize it well here. We have our well, this is not really helping us for the rotator cuff, so let's go here. There's that subscapularis muscle. There is our supraspinatus, so supra meaning above, above the spine of the scapula. We've got our infraspinatus. Notice this muscle is right here, below the spine of the scapula, and then your teres minor. Notice your teres minor is a little bit deeper, so you want to be aware of that. And these are the muscles that can be commonly injured. Think of it with pitchers, but with almost everyone, those muscles can be injured. And they're injured because this joint is a ball and socket joint. It's got a huge range of motion, but with that huge range of motion comes instability. And so the instability is counteracted by these muscles, but that means that they're getting a lot of work when we're doing heavy things with the shoulder. We've got the muscles of the forearm. A couple of things I want to highlight are the extensor retinaculum and the flexor retinaculum. These are fibrous connective tissue that run along the posterior part of the carpus and the anterior part of the carpus. These, because they're fibrous, they don't stretch. So it's kind of like there is a fixed bracelet in a way around your carpus or around your wrist. If there is inflammation in those muscles, there's not really anywhere for that inflammation and that swelling to go because it's going to swell and then eventually it's going to encounter that retinaculum and you're going to start to have pain and discomfort. So these are part of what's involved, especially the flexor retinaculum in carpal tunnel syndrome. And so that's one way I can remember where it is. The flexor retinaculum is the one that would flex your wrist and or flex the carpus and can be involved in carpal tunnel syndrome. We've got some appendicular muscles of the thigh. I don't have any special tips and tricks for this necessarily. I do think it's interesting that the piriformis muscle was named for the pear. Does it really look pear-shaped? Maybe, maybe not, but sometimes it helps me remember it. And then let's see, I don't know that we can see it here, but if we go to the next one of the leg, we can see the sartorius muscle. Sartorial, the root of the word comes from tailor, and tailor like someone who sews or makes a suit or hems something. And the muscle runs across like the fabric would fall across the tailor's leg when sewing. We've also got some muscles of the lower leg. Again, I'll keep saying it, focus on the list of muscles that is on Canvas. I think one of the things to be aware about is, the fibularis longus. It runs down the lateral portion of the leg where that fibula is. So that's important. And I think it is interesting to note that it actually runs under the foot. So if we look here, it attaches at the base of the first metatarsal bone. So normally we'd think, oh, well, it probably just attaches below itself or inferior on the foot. But because it attaches towards that first metatarsal bone and the medial cuneiform bone, that is what allows us to have that eversion so that we can turn the sole of our foot outward. And then last here are some locations for intramuscular injections, some pros and some cons. So maybe just as you take your exam, have the mindset of like, what's one muscle I could give an injection in. We're familiar with the deltoid. That's where if you get vaccines, you're going to have a vaccine in that deltoid muscle. I think we all dread thinking about the dorsal gluteal and ventral gluteal muscles. The dorsal gluteal area, there's a lot of nerves there, blood vessels, and it's really slowly absorbed. You definitely don't want to inject a nerve with an injection because that can cause paralysis and pain, especially depending, if you're injecting something that can burn or cause a little bit of scarring, that can be bad. But the ventral gluteal region has no nerves or blood vessels and can handle a large volume. So that's why we choose that area. The rectus femoris, so that anterior portion of the thigh, is a great place for self-injection. If you think of people that have EpiPens and they kind of they may also do the injection in the vastus lateralis. Some people will use that for other injections that need to be IM that they're giving at home. So kind of have in mind what might be a location for those intramuscular injections. Once again, you've got these lovely diagrams in your textbook that you can label and give yourself some practice. And here are some answers for you as you practice to get good at writing those words, at recognizing those muscles. Keep in mind as well, when you're looking at any image, what is superficial and what is deep. I find there is nothing more frustrating than looking for a muscle in the place that I think it is, and I just can't find it. And it may be because it's under a muscle, or it may be because the image removed it. So keep those things in mind as you review the muscles. I hope you have a good rest of your day, however long that is, and I will see you next time. Bye bye.